So this is cranial nerve number 9 and number 10, the glossopharyngeal and the vagus nerve. So this, still remember in test 1 neurosciences, they brought a diagram like this, wanted us to identify all these nuclei that you can see here. So you just get to look at them, identify which nucleus is which one. Again, this is showing us where the cranial nerves are exiting. This is the ventral view of the brainstem. We've already discussed it. So the glossopharyngeal nerve is principally a sensory nerve with a preganglionic parasympathetic and few motor fibers. It's a mixed nerve, but most of the fibers are going to be sensory. It has got no real nucleus to itself, but it shares nuclei with cranial nerve number 7, which is the facial and the vagus. Okay. So when you look at where this nerve attaches, it is going to arise. Remember, you have got the forebrain. So from the forebrain, you have got cranial nerve number 1 and number 2. And then you have got the midbrain, number 3 and number 4. And then you have got the pons, number 5, 6, 7, 8. And then you have got the medulla oblongata, where you have got 9. So 9 is, I'm supposed to put 1 and x. So 9, 10, 11, and 12. So this is how the cranial nerves exit. First 2 and second 2, next 4, and the last 4. So glossopharyngeal nerve, as you can see here, is going to emerge from the ventral aspect of the medulla, the front of the medulla, okay, by a series of small rootlets. It grooves between olive and inferior cerebellar peduncle, okay, between the olives and the inferior cerebellar peduncle. This is the nerve here, glossopharyngeal. This structure here is what we call the olives. This is the pyramid. So it is actually on the post olivary fissure behind the olives. And then it will leave the cranial cavity by passing through the jugular foramen in company with the vagus and the accessory nerve and the internal jugular vein. This is the jugular foramen. We already looked at the osteology. That's the jugular foramen, which is just posterior to the carotid canal, right? Yeah. So please take note of where it comes from. Jugular foramen. And that's probably, the name is because of the internal jugular vein. So in the jugular foramen, you have got cranial nerve number 9, number 10, all right, and number 11. Number 12, which is the hypoglossal, it has got its own canal, which we call the hypoglossal canal. That's where it will be able to exit from. So again, you can see here cranial nerve number 9, number 10, and number 11. Can you see where they are coming from here? They are together with you have got the jugular vein in the jugular foramen here, and then you have got these structures there coming out. This is the cochlea part of this ear. So how does this nerve moves? It is going to pass forward between the internal jugular vein and the external carotid. Okay, internal jugular vein. Look at this structure. The internal jugular vein is here, and then you have got the carotid. This guy, you can see this guy here, that's a carotid, and it is passing between them. You can see that's the ninth cranial nerve. So the ninth cranial nerve is this one that has been labeled here. Actually, these cranial nerves will be moving in what we call the carotid canal. If you remember, we talked about the carotid canal when we were talking about the neck. But what happens is that cranial nerve number 9 and the other cranial nerves are going to leave the canal if they don't continue going down. It's only the vagus that remains alone in the carotid canal. And this nerve lies deep the styloid process is inside. Okay. It passes between external and internal carotid arteries at the posterior border of stylopharyngeus, then lateral to it. This is just talking more about the relationships. Let's look at the stylopharyngeus. Stylo just means it's attaching to the styloid process, which is a gamma process that is on the somewhere here. Pharyngeus is attaching to the pharynx, so you can see this muscle, which we are calling as the stylopharyngeus, is actually going down like this, touching to the pharynx and then to the styloid process. And this nerve actually passes uh, posterior border, like just behind. You can see just behind. Okay, just behind to this stylopharyngeus, and then lateral to it, meaning that the stylopharyngeus is more medial, but this guy is lateral. And then it reaches the pharynx by passing between middle and inferior constrictor. When you look at the muscles of the pharynx, you have got the superior constrictor, the middle constrictor, and the inferior constrictor. So this one is going to pass between the middle and the inferior constrictor, deep to the hyoglossus. Hyoglossus, this is a muscle of the tongue, okay, where it breaks into the terminal branches. So it is deep to the hyoglossus. The term deep means that it is more inside in comparison to the hyoglossus. Again, you can see the nerve going like that, passing in the jugular foramen. And then you have got the superior ganglion there. And then it continues to go down. Okay. And then at this point, it is ending up giving you the branches. So what are the nuclei where this cranial nerve exists from? Remember we said that it has got no nucleus of its own, but there is the nucleus ambicus. This one will give you the special visceral efferent. So the part that supplies some muscles in the neck, like the stylopharyngeus. So just take note of the nucleus ambicus, and then the inferior salivatory nucleus, which relays in the otic ganglion. It will take the fibers in the otic ganglion. The postsynaptic fibers will supply the parotid gland. So from the inferior salivatory nucleus. You also have these fibers which arises from the cells of the inferior ganglion, and then their fibers terminate in the nucleus of tractus solitarius. And these ones are for taste. Remember we said that the taste sensation from the posterior two-thirds of the tongue, and also the general sensation from the posterior, not two-thirds but one-third of the tongue posterior, is via the glossopharyngeal, and the nucleus to which they terminate is the nucleus solitarius or the nucleus of tractus solitarius. And then you have got those fibers that end in the nucleus of solitary tract. These ones are going to be for visceral sensation. So the first fibers are rising from the inferior ganglion. The inferior ganglion. So here we have got this ganglion here. This is where their fibers are coming from. And then the fibers will terminate in the nucleus tractus solitarius, and those are the ones for taste. But those that ends in in the nucleus of solitary tract or tractus solitarius, these are the ones now that will go down to the visceral sensation to pick up pain and temperature from the mucosa of the posterior third of the tongue, pharynx, auditory tube, and tympanic. Okay, so take note. The same nucleus of solitary tractus, you are having a general sensation and taste sensation. For the general sensation is the end of the nucleus. But for taste sensation, the fibers are coming from the otic inferior ganglion and then just terminating in this guy, this nucleus tractus solitarius. So the superior ganglion, think of S as a superior ganglion is small, with no branches, and it is connected to the superior cervical sympathetic ganglion. The inferior ganglion is large and carries general sensation from the pharynx, soft palate, and tonsils. Remember, general. The trunk of the nerve is connected to the facial nerve at the stylomastoid foramen. When you look at the branches of cranial nerve number 9, you have got the tympanic branch, which is going to lay in the otic ganglion here, and it will give secretomotor to the parotid gland, meaning that it will cause the parotid gland to release its contents. You also have the nerve to the stylopharyngeus muscle, okay, even from the name stylopharyngeus muscle. And then you have got the pharyngeal nerve, which goes to the mucosa of the pharynx, the tonsillar, and the lingual nerve. The lingual nerve is going to the tongue, which carries these sensory branches, general and spatial, from the posterior third of the tongue. And then you also have some sensory branches from the carotid sinus and body. These ones are chemoreceptors and presoreceptors. So they'll be able just to detect changes in chemicals. These are sensory to the carotid sinus. Remember, carotid sinus, the carotid body will pick up these changes in chemicals. And these are the branches which are showed here. What happens if there's a lesion to cranial nerve number 9? There's going to be difficulty in swallowing, impaired of taste and general sensation over the posterior one third of the tongue, palate, and pharynx. There's also going to be no gag reflex because there's dysfunction of the uh, parotid gland, okay, which it is a salivatory gland dysfunction will lead to dry mouth. So the mouth becomes dry because you can't secrete saliva. The gag reflex, what happens is that when you get your fingers, try to put them in your mouth, you feel like vomiting. And that's a gag reflex, and that's initiated by this cranial nerve. Okay. So how do you test if there's injury to cranial nerve number 9? So you ask the patient to open the mouth and inspect the palate arch on each side of the in on each side, and you're trying to look for symmetry. What are you trying to look at? Palatal arch, palatal arch. Okay. So you are basically looking at this top here. Is it symmetrical, like on the left and on the right? You are going to ask the patient to say ah as long as possible, and then you observe the palatal arch as they contract, and the soft palate is going to swing up and back in order to close off the nasopharynx from the oropharynx. So the normal arch will constrict and elevate, and the uvula will remain in the midline as it is elevated. With paralysis, there is no elevation of or constriction of the affected side. When the patient that you are going to test the gag reflex, then to touch first one and then the other palate arch with a tongue blade, waiting each time for gagging, like as so someone wants to void. So what we are saying is this: when you ask the patient to say "ha," you'll be looking at the palate. If it deviates, right? If it deviates to the left, you expect that injury is going to be the other side. Okay. And then if it deviates to the right, you expect that there is injury over the other side. The vagus nerve is a mixed nerve carrying both sensory and motor. The principal role of the vagus is to provide parasympathetic supply to organs throughout the thoracic. Remember, the parasympathetic is cranial sacral. Okay, cranial sacral, and from the cranium, cranial nerve number 10 is part of those nerves which are parasympathetic in nature. It is also going to give sensory and motor supply to the pharynx and to the larynx. It has got two ganglion, the superior ganglion, which is in the jugular foramen, and then the inferior ganglion just below the jugular foramen. This nerve actually leaves the skull via the jugular foramen, right? And its rootlets exit from the medulla between the olive and the inferior cerebellar peduncle. Remember, between olive and inferior cerebellar peduncle. I've been showing the olives, right? So from the jugular foramen, it occupies the posterior aspect of the carotid sheath. This is important, posterior aspect of the carotid sheath, because you are going to have the internal jugular vein, and then you are going to have the carotid artery, and then between them you have got the vagus, okay, in the carotid sheath. That's important. So the superior ganglion will communicate with the inferior ganglion of the glossopharyngeal nerve, the superior cervical sympathetic ganglion, and also the facial nerve. Inferior ganglion communicates with the accessory nerve, the cranial part of cranial nerve number 11, because it has got the spinal part and the cranial part, hypoglossal nerve, and then the superior cervical sympathetic ganglion and the first cervical nerves. Not much you need to really swatter there. But how does this nerve move? The vagus is going to go down the neck on the prevertebral muscles of and fascia. Internal jugular vein lies behind it. So please just take note that the vagus is in front. Relationship is important when it comes to even identifying pictures in your practical exam. Internal jugular vein is going to be behind the vagus. Internal and common carotid arteries are in front, because the common carotid will bifurcate into internal carotid and external carotid. So the internal carotid is in front, and then it lies on the prevertebral muscles and fascia, enters thoracic through its inlets. The right vagus, this is important, it descends in front of the right subclavian artery. Okay, right subclavian. The left vagus descends between the left common carotid and the subclavian artery. Hope you can see how the structure is. This is the one on the right. This is the vagus, which is in front of the right subclavian. Okay, this is the subclavian on the right, and it's in front. While the left will descend between the left common carotid. The left common carotid is going to be this structure that is going up, okay, and the subclavian artery. Subclavian is this one going this side. So it'll be passing between those two. When you look at the nucleus, you have got the nucleus ambicus, goes to the pharynx and the larynx. You have got the dorsal nucleus or the vagus, and this one will give short postganglionic fibers which innervate the heart and smooth muscles and glands. Spinal tract and the nucleus of trigeminal. This is another nucleus sensation from the auricle, external acoustic meatus, and the dura mater. Nucleus of solitary tract. This one carries impulses from the viscera. And this picture has been coming in, I think it came in test one, also in the exam. So it's important for you to know it. But that's not for head and neck. It's neuroscience. So when you look at the branches of cranial nerve number 10, I've got the meningeal branch which supplies dura, auricular nerve which supplies external acoustic meatus and the tympanic membrane, pharyngeal branch which enters the wall of the pharynx, okay, to and supplies mucous membrane of the pharynx, superior and middle constrictor muscles, all the muscles of the palate except tensor palatine. So please take note, all the muscles of the palate are supplied by cranial nerve number 10 via the pharyngeal artery except the tensor palate or palatine. You also have the superior laryngeal, which divides into internal laryngeal and external laryngeal. So the internal provides sensation to the hypopharynx. Hypopharynx is also known as the laryngopharynx, and the epiglottis and the part of the larynx that lies above the vocal cord. For now, you don't even know the vocal cords, right? But you understand later. External laryngeal supplies the cricothyroid muscle. Cricothyroid, it attaches to the cricoid cartilage and the thyroid. That's how the nerve goes. It's a big. So we also have what we call the recurrent laryngeal nerve. Recurrent laryngeal nerve goes around the subclavian artery on the right. We've been talking about this in anatomy last year, and it will go around the arc of the aorta on the left. It runs upwards and medially. So what is important is that this recurrent laryngeal supplies all the muscles of the larynx except thyroid. What supplies the thyroid is the external laryngeal, right? And it's important to understand that it provides sensation. The same recurrent laryngeal provides sensation to the larynx below the vocal cords. And so if there is injury to this nerve, what happens is that maybe when you are trying to remove the thyroid gland during thyroidectomy, it will lead to hoarseness and complete loss of voice. Please take note, they're going to tell you what nerve is involved when there is hoarseness or complete loss of voice. That's the recurrent laryngeal nerve. So if there's a lesion to this nerve, it can produce also palatal and pharyngeal and laryngeal paralysis. Okay. So how to diagnose that someone has got an injury to this nerve? Listen to the patient talk as you are taking the history. There's going to be hoarseness of the voice, whispering, nasal speech, or complete of aspiration, or regurgitation of liquid through the nose. Okay. So they give the patient a glass of water to see if there is choking or any complaint as it is swallowed, because they literally can't swallow the water, so they can choke. And this nerve actually supplies most of the organs that are present in the abdomen. Okay. So when there's a region to cranial nerve number 9 and cranial nerve number 10, both of them, what are the causes? There's what is called the lateral medullary syndrome, a degenerative disorder that happens over 50 years. If there's the thrombosis of the inferior cerebellar artery, when there is thrombosis, meaning that there is actually a clot in this artery. Okay. And what happens is that that can end up compressing all these nerves. Besides, so that's the lateral medullary syndrome. Inferior cerebellar artery, this one that has been pointed there. And then you also have tumors that can compress this cranial nerve, and so it can end up causing compression of both 9 and 10. So there's going to be ipsilateral paralysis of muscles of the palate, pharynx, and the larynx, ipsilateral loss of taste from the posterior third of the tongue because of cranial nerve number 9. So that is that, and this is just a summary about these two cranial nerves. And that is where we end. Thank you so much for watching.